Hello, this is the menopause video and the last lecture as part of the Women's Health series for pharmacotherapeutics. As with past sections, the topic on UB Learns has instructions for students and the videos links will be posted there. There is a packet and then additional readings for menopause, which include a number of different things that are useful to read if you have the time to spend on it. The one I would spend the most time if you were going to read any of them would be the most recent hormone therapy position statement from NAMS, which is the North American Menopause Society, and the place that we get a lot of these recommendations from. Otherwise, you can just focus on the packet and the cases that we'll go through in class. So we'll start right at the menopause background. So if we remember back to our HPO axis, our hypothalamus is secreting gonadotropin-releasing hormone that's acting on the anterior pituitary, and then the anterior pituitary releases our gonadotropins, LH and FSH, and then those act on the ovary to cause release of estrogen and progesterone. And then there's negative and positive feedback that works as part of an entire feedback loop throughout the system. As a woman ages, ovarian function begins to decline. The number of eggs begins to decline, and thus the amount of estrogen that is produced will begin to decline. As compensation for that, because of that feedback loop, the body starts to upregulate production of FSH to try to stimulate more eggs to be released to produce more estrogen. So when we talk about menopause, it's really that cessation of ovarian function. And there's a couple definitions that are specific to the time period. So menopause itself is a physiologic event that occurs 1 year after the last menstrual period. It's characterized by an FSH greater than 40 units, which is elevated. So then we would know that the body is trying to upregulate and there is not enough estrogen being produced. There's also perimenopause, which is the immediate time period prior to menopause and the first year after it begins. So it's a 2-year time period that's defined as perimenopause. And then women are considered postmenopausal when they're up to 1 year after menopause begins. So after that perimenopausal period, they'll be considered postmenopausal. The median age of onset is 51 years, so patients may experience menopausal symptoms before or after this time period. Smokers on average will experience symptoms earlier, and if a patient has a full hysterectomy during which they remove the ovaries as well, they will have an earlier onset of menopause around the time of removal. The cause of menopause will be either natural, meaning as a result of age, ovarian function declines, as a surgical, so like I said before, if the ovaries were removed as part of an oophorectomy with or without a hysterectomy, as a result of chemotherapy or pelvic radiation that would damage the ovaries and decrease production of estrogen. So as we look through our time period that we've been talking about throughout this whole time, we spent a lot of time in the early part of life in contraception, infertility, pregnancy, menstruation disorders, lactation. But women really spend most of their life in this menopausal period, especially when life expectancy has been around 80 years. We talked a bit about the pathophysiology. So because of that decline in ovarian function, the clinical presentation can be multifold. And this is because there are estrogen receptors in multiple places throughout the body. There are estrogen receptors on the hypothalamus, on breast tissue, on bone, in the liver, in the endometrial tissue, in the uterus, in the vagina. All of these places will have estrogen receptors, and a decrease in the amount of estrogen around in the body will result in different types of symptoms for different patients. Usually we classify symptoms as either vasomotor or urogenital symptoms. The vasomotor symptoms are hot flashes, or sometimes characterized as hot flushes or night sweats, and they can occur 12 to 24 months after the last menstrual period. So sometimes patients won't be presenting with those symptoms right away. The urogenital symptoms can include vaginal dryness or atrophy, dyspareunia, which is a painful intercourse, atrophic vaginitis, recurrent UTIs, and incontinence. Additionally, these other symptoms are often associated with menopause, mood changes, sleep disturbances, which may or may not be due to the vasomotor symptoms, a difficulty with concentration and memory, and osteoporosis, all because of decreases in estrogen. Now, when we're assessing for appropriateness of hormone therapy or pharmacologic management, we have to consider the same way we talked about for contraception, what the indications are, why we're using it, and what the contraindications are. So the FDA-approved indications and absolute contraindications you will have to memorize. There's no handy chart like there is for contraception that will tell you all the times when things are contraindicated in different disease states. So you do have to pretty much memorize the FDA-approved indications and the absolute contraindications. We have to remember that when we're treating patients, they have to be displaying moderate to severe symptoms. So either moderate to severe vasomotor symptoms or moderate to severe urogenital symptoms. That means that they're significantly impacting the woman's life. Mild symptoms should be treated with non-pharmacologic or OTC options and would not qualify the woman for hormone therapy because the benefit would not outweigh the risk. These absolute contraindications are mostly related to the side effects of hormone therapy, so undiagnosed vaginal bleeding, which can be a sign of endometrial cancer, known or suspected breast cancer, known or suspected estrogen or progestin-dependent neoplasm, active or history of a VTE or blood clot, active or recent MI or stroke, and then liver disease or dysfunction. Additionally, there are a number of different relative contraindications. These would really only come into play if a patient had several of them. So if a patient, say, had several different relative contraindications, I would consider that almost equivalent to an absolute contraindication. So when we're thinking about therapy, we always, again, want to start with non-pharmacologic therapy. So some of this is obvious: wearing layers that can be removed, lowering the room temperature, decreasing triggers like spicy food, caffeine, and hot beverages. There are over-the-counter vaginal lubricants that can be beneficial for the urogenital symptoms. And then the lifestyle modifications of weight loss and smoking cessation have been shown to improve especially the vasomotor symptoms. Because a lot of these symptoms are very bothersome and patients may complain of increased stress related to them, difficulty concentrating, things such as yoga and relaxation techniques can be really helpful, physical exercise, in helping to manage some of those additional symptoms of menopause. There are some herbal therapies, as you can review in the chart. Probably the two most common are black cohosh and phytoestrogens. There are conflicting reports of evidence for menopausal symptoms for black cohosh, and then the phytoestrogens are things such as soy products. These might have slightly more benefit, although reviews have not supported that. And side effects are limited though, so if a patient does want to try these, they might not see a benefit, but it's probably not going to harm them, as opposed to black cohosh, which has reported liver toxicity with it. And I always tell the story that my mom, when she went through menopause, she really swore by soy milk and how it really helped her vasomotor symptoms. So I guess for some patients it really works, or maybe it's just placebo effect. Okay, so when non-pharmacologic or OTC or herbal options have failed, and we want to move to hormone therapy because the patient has an indication and no contraindications, absolute contraindications, we have to consider either giving the patient estrogen alone or estrogen plus progestin. So the way that we decide this, the estrogen products are listed here, but the way that we decide if the patient needs progestin added to their therapy is whether or not they have an intact uterus. So estrogen can be given to all patients that have has vasomotor symptoms, but progestin would only be added to patients that have an intact uterus. The reason for this is that unopposed estrogen without the progestin will lead to endometrial hyperplasia and increase the risk of endometrial cancer. So the progestin is given to prevent endometrial cancer. The only time you would not need the progestin is if the woman no longer had an endometrium, so she no longer has a uterus. If she no longer has a uterus, you don't need the progestin. So you can remember this. If it's not there, we don't care about adding a progestin. So for the estrogens, there are a number of different preparations. Most of them come in either a conjugated equine estrogen, which is a product like Premarin that has estrogens that are derived from pregnant mare's urine. That's where the name Premarin comes from. And then synthetic estradiol, 17-beta estradiol. So a lot of these different forms come in both a natural product and a synthetic product, and then either an oral, transdermal, topical, vaginal, or implanted estrogen. Progestins usually come as an oral product and can be given in different regimens. When we talk about the treatment, we'll focus on that. So in terms of the treatment regimen, we usually initiate hormone therapy in any patient that has an indication without a contraindication, who is less than 60 years old and within 10 years of the onset of menopause. This is the group, and it's in the last 2017 NAMS position statement, that really benefits the most from hormone therapy, especially patients who would otherwise be considered healthy. If the patient is older than this or more years out, it's a little bit controversial because the risk starts to outweigh the benefit. There used to be a practice where hormone therapy would automatically be discontinued after the age of 65, but this should really be individualized per patient and dependent on their risk, whether or not they've developed contraindications, and whether or not they still have an indication or are still experiencing symptoms. So there's several different regimens of ways that progestins can be added to the estrogen if the woman has an intact uterus. There's continuous cyclic, continuous combined, continuous long cycle, and intermittent combined. I'm really just going to focus on the first two because these are the most common, and even out of those two, continuous combined is the most accepted regimen. This is when progestin and estrogen is given every day. It's associated with an absence of vaginal bleeding, so there's no withdrawal bleeding, although they might experience spotting for the first 6 to 12 months. Continuous cyclic, a lot of combination products come as continuous cyclic products as well, and this is when the estrogen or progestin is given for the last 12 to 14 days of the cycle, and this creates a withdrawal bleed that occurs in 90% of women. So they'll have something that appears to be like a period every month. Most women would prefer not to have that because they feel like, I'm in menopause, I shouldn't, have to deal with having a period again. So most accepted regimen would be continuous combined. There's also a long cycle that does every other month, and then an intermittent combined or a pulsed regimen, but those are less common.